Thanks, guys. It's a couple minutes after 4 o'clock. I know everybody has to get somewhere. I have to get back to a third revision thyroid. So I'm just going to quickly introduce the group here. We're super fortunate this week. We've got a bunch of multidisciplinary folks joining us. Courtney Enslin, from a dermatologist from Mount Sinai. We also had Fade Mahmood joining us, a melanoma oncologist from Banner MD Anderson. Really fortunate to have you joining us, and thanks for being here today. In addition, we have Brittany Tillman. Nobody needs an introduction from her, a head neck surgeon at UT Southwestern. Thanks for joining us, Brittany. And then we've got our fellow presenters, Peter Lancione with Dr. Booley from UC Davis here today, Daniel Benito and Peter D here from University of Florida, and Claudia Gutierrez and Larissa Sweeney as her faculty from University of Miami. And thanks so much to Chris Vannison and Alice Lynn for setting this up. This is an all-star panel, and we're super fortunate to have everybody here today. So I'll let Chris take it away. Thanks so
Great.
much.
Yeah, no, thank you guys for the opportunity. I think we got a good cohort of cases today, some pretty complex stuff. But thank you to our panelists for joining, and thanks for the fellows. I know you guys are kind of transitioning to your jobs right now, so it's a busy time. So thank you guys for putting together these cases. And special kudos to Claudia and Larissa, because you guys put together something at like the 11th and a half hour. So thank you for that. I think we'll start off with Dr. Benito from University of Florida on his case. So Dan, if you don't mind pulling up your slides, what I'll do is I'll kind of butt in from time to time to ask some questions. And anybody else in the audience, feel free to raise a hand, and we'll try to keep an eye out for that. Try to make this pretty fluid.
All right, awesome. All right, thank you, Dr. Vanison, and the rest of the team for giving us the opportunity to present a case here. Let me just pull up my slides. Perfect. So our case involves a 74-year-old female who presented with a pigmented right scalp lesion for about 2 months. Let me just minimize this. Oops. Biopsied by an outside dermatologist. Initially, so it was read as a melanoma in situ without much detail besides that. She denied any prior head and neck cancers, skin cancers, no other notable past medical history, and socially, just never smoker, and an occasional alcohol drinker, actually a frequent alcohol drinker. Um, so in physical exam, this is what the lesion looked like. It was, as noted before, raised, pigmented there on the right parietal scalp, just kind of right above the root of the helix there. Hard to see. I don't know if you guys can see it come through on the PowerPoint there, but there's still some hair there over it. But it kind of just starts right above the root of the helix and kind of extends back for about a 3 centimeter width. Um, the rest of her exam was pretty. Head and neck exam was normal face. No other masses or lesions noted. Cranial nerve exam was noted. It was normal. Her parotid exam was normal as well as no cervical lymphadenopathy was palpable. Um, so we uh, so we got the path we reviewed at here at our institution, and basically just showed a broadly poorly circumscribed proliferation of atypical melanocytes at the dermal epidermal junction. No other zones of confluence of melanocytes are present along the basal layer. No other information besides this. So this is what her
Dan, actually, do you
imaging.
mind? I just want to ask a couple of questions. Do you mind going back to
Yeah,
the actual picture? I know it's a bit hard to see, but if you can get like the one slide prior. I wanted to ask actually, I wanted to ask Dr. Enslin, when you have a lesion like this in your clinic, and the biopsy shows melanoma in situ, are there any situations where you might look at a lesion either with a dermoscope or grossly and say, hey, this is kind of concerning. I'm not really sure if I trust this pathology. Be curious to hear what you think about that.
Hi, thank you. And yes, thank you guys for having me. So I'm a dermatologist and I'm actually also a Mohs surgeon at Mount Sinai. And I'm glad you asked this question because commonly for broad lesions like this, I mean, looking at this is like a slam dunk lentigo maligna based on the size, the location, sun exposed area. But oftentimes, dermatologists are hesitant to take a 3 centimeter biopsy on the face, right? So people will often do either punch biopsies of the darkest area. The darkest area is usually signifying where there are melanocytes deeper. For example, blue nevi, the reason they look blue is because pigment is extending so deep. It's the reflection of light against the pigment that makes them look blue. When I see these patients, if they've had a biopsy, I often will bring them in clinic and examine the area. And if the entire lesion wasn't biopsied, what I do is remove the entire thing. I will saucerize, aka scoop shave with a derma blade, or use my scalpel and very thinly take out the whole pigmented area. And we call that micro staging. Essentially, I want to know if there is deeper invasion prior to treating this lesion. So I would be curious, when you guys saw this patient, if the dermatologist had only partially biopsied an area, which is what I anticipate happened in this case based on the size.
Mhm.
And usually that's my next step with these patients.
Great. No, thank you.
Yeah.
That was great. Dan.
Yeah, thank you for that for those points. Yeah, it was only partially biopsied. That's correct.
All right, why don't
So
you yeah, keep on going.
and then the only notable thing here is that there's lesion obviously still present at the lateral edge, um, and stained as expected for SOX10 marker. And here is the imaging. I was testing my slides earlier. The bottom and the top were also scans here, but only the PET came through. So we'll just quickly scroll through that. But essentially, her MRI brain was negative, PET CT was negative, just showed like a hiatal hernia, nothing major. And there were notable like level 2 and level 3 nodes of lymph bilaterally. Like 1.2 centimeters in largest dimension. No, they're like atypical features. They were morphologically normal appearing. Um,
What
so
prompted you
we
guys to get imaging with the melanoma in situ? I'm just curious. Is it like institutional protocol or?
She actually arrived with all this workup prior to
Oh,
getting here to University of Florida. So yeah, she had already had this ordered. Yes, we didn't actually at this point in her clinical course order any additional imaging. So so then so she at this point in time staged her as a in situ melanoma, basically presented her at tumor board. The NC guidelines there are down there pasted, but the we recommended basically at this point a wide local excision with a skin thickness, a split thickness skin graft, and then just potentially any adjuvant treatment, just depending on what the final path showed. So we took her to the operating room and performed a wide local excision of that right scalp lesion. Because of the questionable biopsy, we decided to go. We went out to 2 centimeter margins. Typically for depending on obviously the thickness, 1 to 2 for most of these is what's recommended. But we essentially resected her lesion out to 2 centimeters, and the final path ended up showing a T2A, a lentigo malignant melanoma, as previously foreshadowed. And But no other adverse features there in terms of no LVI, no ulceration, no macroscopic cytolitosis. Breslow's depth was 1.7 centimeters. There were tumor infiltrating lymphocytes noted, and her margins. The only close margin was at the deepest aspect of the lesion, 4 millimeters, though. Everywhere else, it was 8 to 1 millimeters out. So
I'm gonna
I'm
step in
sorry,
again,
8 to 1,
Dan, real
1 centimeter.
quick.
Yeah,
Yeah, I'm
yeah.
just gonna ask the panelists some questions. This one's for Dr. Tillman. I'm curious, are there any situations when, say like before this pathology, when you were planning surgery, are there any situations where you might leave the wound unreconstructed, pending pathology in your practice?
Um, yes and no. I think that the key is to ensure negative margins before you do any complex reconstruction. You certainly don't want to burn any bridges. You want to be able to go back and re-resect any positive margins, especially in older folks or patients that are undergoing simple reconstruction. A skin graft is totally reasonable as long as they know that, hey, if we have to go back and re-resect a positive margin, we will have to do something more. The same thing goes for biologics. And then, if I can close something very simply in an ellipse that could be re-excised, then I'll certainly do that as well, to save people another trip to the OR.
Yeah, I think that's a great point. I mean, I think in this situation, you know where the margins are going to be because it's the same shape as the excision. So, I think this is a good one to reconstruct at the same time. And I have a question for Dr. Enslin again. I feel like this comes up in every melanoma tumor board year after year, but so I'm gonna discuss it too. But I'm curious if you think at this point in time, before doing anything further, if there's any role for like gene expression profiling, like Castle testing, is that going to help the situation at all? I mean, it's not really the time where it's typically done, but I guess in your thoughts.
Yeah, I view Castle just as like another data point. It doesn't make or break my management, but I think that it's beneficial. I've seen it go both ways where you get a class A result and then they still metastasize. But I feel like if I were the patient, I would prefer to have it done, have that information, because especially if it is a high risk GEP result, then at least you have that and you know to screen the patient more frequently with imaging, keep a closer eye on them. I agree with you at this kind of time point. It is kind of an odd time to order Castle. You usually order it on the biopsy specimen, and they're pretty specific about that. I'm not sure if anyone else has ran into that issue, but when you send them the excision, sometimes they'll refuse to run it. So I would be curious what they would do in a situation like this. And I traditionally will order Castle for any melanoma with depth of invasion greater than 0.3 millimeters. I always discuss it with the patient and just tell them it's another data point that we'll use for their care. But I do think it's valuable, and I think it would be reasonable to consider for her at this point.
Awesome. Thank you for that. The we After the OR, let me see, go here. So after we decided to based on her final path from that surgery, we decided she was most appropriate to proceed with a sentinel lymph node biopsy. We at that point did repeat some of her imaging, PET and MRI brain, just to do the interval between initial biopsy and then her final OR day, which is about the delay was like about 4 to 5 months. Um, I believe she's not a snowbird, but I think there were some factors that impeded kind of follow up there. But she, her MRI at that point was negative. PET CT did show, um, not too surprisingly, some new moderate uptake over the scalp post-surgically, which could have represented, of course, either post-treatment changes or disease not excluded, of course, but no evidence at that point of any distant spread. So we took her to the OR on then later, about a month and a half later, for sentinel lymph node biopsy. Um, and this is her SPECT CT right over. Or that it's so fast. Let me see if I could slow it down or just scroll through this. But um, here at our institution, the radiologists can go ahead and inject the primary lesion. And I don't know if everyone can see it there, but um, interestingly, there were better images showing uptake in the parotid bed as well as kind of 1B/2A. So we essentially went to the OR for sentinel lymph node biopsy, found tracked into those basins, and ultimately those lymph nodes were negative. Represented her at tumor board, and the NCCN guidelines just pasted right below. But she was given the option of observation. There was no adverse features at this point to really warrant RT. That was offered up by as a discussion point with our radiation oncologist colleagues. But we at this time are just serially observing her, and she's just completed her first interval follow-up. She was done at the end of March, and then we just saw her recently post-op, but for one of our serial post-op visits. But um, she's ultimately a stage 1B um, melanoma. So there's no, at this point, to my knowledge, I think there's no indication for any adjuvant immunotherapy, certainly not radiation therapy, based on the guidelines. I did look up, just because this was in the most recent NCCN, a study that was done in the Journal of the National Cancer Institute. And essentially, this is an NCDB study that evaluated all T2 to T4 disease between 2010 and 2020, had about over 800,000 patients in their cohorts, which they divided into patients that either presented with the clinically N0 next that were either ultimately found to be negative or positive on sentinel lymph node biopsy, and compared those to people who presented with N positive and then confirmed nodal disease. And the primary outcome was just to evaluate for the risk factors associated with distant metastases found serially in these patients. And so I just pasted what the ultimate nomogram that represents kind of the cohort that this patient would fall into. And so the highest risk factors with the associated like highest hazard ratios essentially were patients that male, age 50 to 59, non-mitogenic tumors, tumors with extensive neurotropism, ulcerations, Bresla depths greater than 4 millimeters, nodular subtypes, LVI, and then yeah, ulceration as I mentioned, and then Bresla thickness. Sorry, I guess that repeated, but yeah, so this patient's, we felt more than appropriate to observe, and so. And that's our case.
Yeah, no, great. And I think somebody from the audience asked a question, and it was actually something I was going to pose. So great minds think alike. But I think the concern was, what's the prognostic value of doing a delayed sentinel lymph node biopsy? So I was going to ask Dr. Tillman, I guess in your practice situation like this, how would you approach the sentinel lymph node biopsy? Are there situations where you would say, hey, this is just not going to pan out? How do you counsel the patient, et cetera?
I think that it really depends on what exactly has been done. Was it a pretty small excision and that granulated, or was this something that was really large and a local flap reconstruction was performed? My personal experience is they're more likely to not localize, but I know there's some more recent studies that show some amazing success. So that's a little bit anecdotal. So I typically offer it. A lot of the times I find that the radio tracer, if was any sort of significant closure, will often kind of get stuck in the scar tissue. It just doesn't migrate. I always just counsel patients that, it is an option that we can consider. It may not be as accurate, but I too love to get more information when it's possible. And so I typically am generally open to offering it with those caveats.
Great. Yeah, it's a tricky situation when that happens, and I think there's a lot of factors to consider, like you said. Question for Dr. Mahmood. Is there any role to get BRAF testing at this point in time if it's not already been done, or is this just such a low stage disease that it's not really that important?
Yeah, definitely. I would not do a BRAF testing for her. I think right now the adjuvant treatment or the indication for adjuvant treatment in melanoma is from stage 2B, 2C, stage 3 and 4 completely resected. So I agree with the comments that adjuvant immunotherapy is not indicated in this case. I would also, agree with that adjuvant radiation therapy is not indicated. I have a couple of comments about the Castle test. I mean, it has not been validated. There's a lot of controversies. I agree with the speakers from the dermatologists that even I have seen class A, this wonderful class. I mean, they give you those classes A and B and C and D. I think if you talk to me about that, I tell you, please talk to me about the depth of the melanoma, the ulceration status, and the lymph node involvement. I think we have to be really careful about the Castle test that has not been yet validated. But I think it's a data point. I respect that, but I think we should be careful about Castle. I have seen class A; they have stage 4 disease, and I have worst class B and C, and I honestly don't know them because I don't order that test. They do well. So that's about the Castle. And in terms of the imaging, I mean, for a thin melanoma, I felt that this patient had a lot of imaging, PET-CT scans and MRIs, and I don't know if really it's indicated for a thin melanoma like this. So these are my comments. Thanks.
Yeah, thank you. And then just before we go to the next case, just a hypothetical, because I think this is important for the fellows, because you will encounter this in your practice. Probably pose this to both Dr. Tillman and Dr. Enslin. Suppose at the end of this, the invasive melanoma was completely excised, but there was a positive margin for melanoma in situ. What's the next step? Is this something we can observe, or is this like a must treat situation?
I think it depends on how big of a resection it was, what the residual lesion looks like. If they have a lot of pigmentation still remaining and you're worried, sometimes it's like very frustrating. You might keep going and going. And so, if this was a MART1 positive tumor, I might send this patient to my dermatology colleagues to clear that area. And then, there are some other options. I'll let you weigh in, Courtney.
Yeah, thanks. I agree. I think that the morbidity of resecting it is low. And I think, especially since this was a melanoma that did show invasive disease already, I would be concerned about further progression from even in situ disease remaining. And I would go after it. I would have a hard time, recommending to a patient to leave a positive margin. That just wouldn't feel right. But I agree with you, Brittany, that the in situ lesions tend to go on. I've done Mohs and slow Mohs for these lesions, and I've gone 5 stages over weeks sometimes. And we actually just had our big Mohs College meeting this past weekend, and everyone was talking about how the cases they see most commonly recur are the lentigo maligna in situ. They can really extend. I'm glad you guys took a 2 centimeter margin here, because if you took a centimeter, I think that you might have had to go back.
I know, I don't know if you do, Courtney, but I typically use a woods lamp and I find it to be helpful a lot of the time when I'm resecting these in the OR. And I think people think I'm a little crazy, but it's very helpful. And then, for say like a really elderly patient in a cosmetically sensitive area, sometimes our Mohs colleagues will offer a Miquimod. Do you have experience with that?
Yeah, I do. I'm glad you brought that up. So, kind of two things there. I use a woods lamp too. We love a woods lamp in dermatology. And I feel like sometimes these cases, there's ones that the borders are still relatively crisp, such as in this case. But we see amelanotic melanomas. We see some with really ill-defined borders, and those would be the cases where I would say, especially if it's in situ disease, to involve your dermatology and Mohs surgeons colleagues, because especially if it's in the surface or superficial, and this is something that's going to be hard to get around, you can actually be doing your patient a favor and sparing them multiple trips. In regards to imiquimod, I view that as really if a patient is unresectable or really doesn't want to proceed with surgery. Imiquimod, we do not see high cure rates. It causes actually significant inflammation, and we often see recurrences after a few years. So it's not something I frequently use for melanoma in situ, unless a patient's, a lot older, a lot of comorbidities, and it's that or nothing.
I think we have time for one quick question before we move on. I think Dr. Geffert has his hand up.
Hey, thanks for this case. It's a nice example of when the biopsy doesn't match what you see. We, as most of us are surgeons, don't usually have or are trained to do these shaved biopsies or the scoop biopsy, like you said, Courtney. But we do have punch biopsies in most of our clinics. And what I would say is if I saw this and I had a diagnosis of melanoma in situ, I just do a punch biopsy. You can even do more than one, and then you obviate all the things that we've then discussed. You avoid this wide excision that then is injected afterwards with sentinel lymph node that you probably don't trust or you're questioning it. And I mean, then you probably would know, hey, this looks like a lentigo maligna, even though it's invasive. The risk of that's very low. I don't know, it's probably less than 5% of a positive sentinel lymph node. So I would just say if something doesn't match what you see, take another biopsy.
Yeah,
But
excellent advice.
quick question. Sorry, quick question for you on that. If you're doing a punch biopsy in clinic, what stops you from just grabbing a scalpel and just kind of going around the lesion and splitting at the dermal subcutaneous junction and just taking like the whole thing off?
We just tend not to do that. I mean, that was a three
Yeah,
centimeter area, then we create a bigger
yeah.
wound and
Yeah, I
uh
think the classic teaching is you want a full thickness biopsy for us anyways in surgery.
Hmm.
But I've talked to my derm path and anytime we see a really broad base pigmented lesion, he wants a really big shave. And I keep
Yeah.
derma shaves in my office. They're pretty cheap and they're really, really helpful. And I think we should all like consider using them more.
Yeah, no, I agree. I just mentioned because you guys are all surgeons, you absolutely can shave this off very easily. And the only hesitation I have with the punch biopsy is again, you still risk not getting the deepest section, right? So you could do a punch and then you find the invasive depth is 0.6 millimeters, but then if you excise it and it actually was 1.7, you could end up in the same scenario. But yeah, I advocate for removing the whole thing, but I read path as part of my job too, so I probably side with the derm paths here.
All right, excellent, guys. All right, thank you, Dan. So we'll move on to Peter's case now.
All right, can everyone see my slides?
Sure can.
Okay. Well, thanks for having me. Let me present a case today. Peter Lancion, I'm the fellow at UC Davis. So our patient is a 69-year-old male. We're going to talk about a complex history of multi-recurrent and immunotherapy-resistant melanoma of the scalp. He's a fair-skinned, thin-haired, avid golfer who has many decades of sun exposure in the state of California. So January 2023 is when his skin cancer history kind of started. He had a shave biopsy for a pigmented lesion of the left frontal scalp, and pathology for that was positive for melanoma in situ. That was followed up by a Mohs procedure shortly after, and pathology from that revealed no residual tumor in the specimen. The picture to the right is the lesion that we'll be talking about for the rest of the presentation of the left parietal scalp. So about 6 months later, he developed a second pigmented lesion that we saw on the last slide on the left parietal scalp, and pathology for this was positive for melanoma. The pathology report can be seen to the right with a depth of at least 0.9 millimeters transected at the base. He was referred to surgical oncology for consideration of wide local excision and sentinel lymph node biopsy.
Quick question for any of the panelists. So, I mean, it says transected at the base, which you often see. So obviously there's a chance that this is deeper, but it's 0.9 and we're going to do a sentinel lymph node biopsy. Is there any point in rebiopsying this with a punch to try and get a more accurate depth, or is it not? Is it kind of moot at this point?
I don't think I would. I mean, because you can offer it for 0.8 or greater, so I would assume, that it's appropriate for a sentinel lymph node personally. I'll typically offer it if the patient is, not very excited about surgery, and then we can always forego it or sorry, offer an additional biopsy. But I tell them it most likely won't change my recommendation personally.
Yeah, I agree. When I'm rebiopsying, it's only to see if it would need a sentinel node usually. So, and just going back to when we were talking about the deeper biopsy, the reason I don't sometimes feel like I have to go to fat is I'm like, I just have to get a millimeter down to see.
All right, Peter, you can keep on going.
So 2 months after that, in December of 2023, he underwent the wide local excision of the scalp lesion and a sentinel lymph node biopsy. His lymphoscintigraphy revealed 2 nodes in left level 5, both of which were negative for melanoma. In the wide excision specimen with 1 centimeter margins, there was no residual melanoma noted, and he underwent bilateral advancement flap closure for local tissue rearrangement. Almost a year later, he was noted to have a recurrent pigmented lesion adjacent to the surgical scar from the last procedure. He underwent shave biopsy again with dermatology, which was positive for melanoma. So about a year after his first wide excision, he underwent a repeat wide excision, a full thickness skin graft, and a repeat sentinel lymph node biopsy by surgical oncology. For the next specimen on this procedure, there were 12 nodes removed. So based on the notes and the pathology, it seems to be more of a mini posterior neck dissection. 2 of 12 were positive and no ENE was identified. And the pathology for the excision specimen was T2B melanoma.
So
Recurrent.
this was still outside of UC Davis?
This was in UC Davis within the surgical oncology.
Oh, gotcha. Okay. Do you know is there any information that you guys have on the nodes? Like, were they macromets, micromets, any other features that would be helpful to know?
Let's see. I can probably find that right now.
Yeah, you don't have to don't take too much time. If it's not readily available, don't worry about it.
5 mm lymph node deposit for this procedure.
Yeah, thanks for finding that.
So after this procedure, he was started on pembrolizumab, and 2 months after initiation of immunotherapy, was noted to have recurrent pigmented lesions adjacent to the skin graft site. Shave biopsy again was positive for melanoma. At this point, he underwent a PET scan, which showed avid left scalp lesion and one densely avid left level 5 lymph node. He had MRI brain, which is negative for brain metastasis. So he was referred to head and neck surgery at this time after discussion with Cutaneous Tumor Board and planned for surgery followed by radiation therapy and need for reconstruction of the scalp. Given he was progressing through pembrolizumab, he was also started on dual checkpoint inhibitor therapy leading up to our planned surgery.
I did want to
Underwent
ask,
these
oh, actually the PET scan, never mind. I was going to ask what made you think he was progressing. One quick question. You said that you sent for mapping biopsies. I just wanted, I think this is important to know because, there's some nuance to it. I wanted to ask Dr. Ensland, what's the strategy for mapping biopsies like in a case like this? I mean, it kind of just looks all like scar, like where are the targeted areas we're going to want to biopsy? Because this will be tasked to us at some point as well.
Yeah, so I think it's interesting because to answer your question, looking at that first photo, the lesion looked actually more pink to me. It looked almost like an amelanotic melanoma. And here it looks like the mapping biopsies were done because there was repigmentation seen around the surgical site. The purpose of the mapping biopsies is usually to just get a sense of how far out there's still tumor. And this makes me concerned for like in transit metastases when we're seeing this, so especially considering where the primary lesion was. So normally we will biopsy areas that look suspicious due to pigmentation, but also some areas where the skin looks normal, because especially if we're concerned for an in-transit metastasis, there might be no epidermal, there should not be any epidermal connection on histology.
Yeah. And so for Dr. Mahmood, so this patient was started, I guess, on the quote unquote neoadjuvant regimen. He'd had treatment previously, but we're kind of restarting. I guess in your practice, what factors do you use to decide if somebody's going to get mono agent versus dual agent neoadjuvant therapy?
Yeah, I mean, I'd like also to echo what the dermatologist said about the in-transit. Whenever I see scalp melanoma that is recurring in this pattern every 6 months to a year, we have a recurrence. Really, I mean, the sensors in my brain saying to me, is this in transit? I will definitely have a talk with the derm path and ask them, is this a dermal melanoma or is this like, a second primary melanoma? I mean, what the chances of second primary melanoma occurring that often within 6 months from the other? So I think that was a very excellent point. In terms of the neoadjuvant treatment, obviously, this is a clinically measurable, seen on the PET-CT scan, stage 3 melanoma now. And there are a couple of options or a couple of trials, important trials. For me, I would always prefer to go with a dual immunotherapy, and I'll make a case for that. So we have the NADINA clinical trial. In the NADINA clinical trial, this is a randomized phase 3 study where people underwent 2 cycles of ipilimumab and nivolumab, followed by completion lymph node dissection. And then after the surgery, based on the pathological response, the treatment is tailored based on the the pathologic response versus the standard of care, the old standard of care, which is the completion lymph node dissection followed by 1 year of nivolumab. And in that trial, the event-free survival, the 12 months event-free survival was 83%. If we want to compare it to the SWOG 1801, which is a brilliant trial, I mean, it is SWOG 1801, basically what they did, they took the traditional standard of care where we used to do a completion lymph node dissection followed by a full year of Keytruda, and they just took 3 cycles and they put it before surgery, and you get a positive study. And in that study, the 12-month event-free survival was about 72%. So, we should be careful about doing a cross-trial comparison. It's not encouraged. But it seems that the dual immunotherapy if you look at any data point, whether you're looking at the pathologic complete response, event-free survival, or recurrence-free survival, and even to the major pathologic response, there is a 10% difference. Again, they were not compared head to head. Hopefully, in the this ASCO meeting, the regional study, which is a phase 2 study, which compared neoadjuvant cemiplimab, which is an anti-PD-L1, with fianlimab, which is a LAG-3. In the neoadjuvant setting, they compared it to cemiplimab. So hopefully we'll have an answer for your question, which is better to go for sure with dual immunotherapy or single agent. For me, based on the available data, and even there is a small study done of 30 patients, a phase 2 study done at MD Anderson in Houston, where they give neoadjuvant Opdualag followed by completion lymph node dissection, followed by 10 additional cycles of Opdualag. And that study was remarkable. The major pathologic response was 70%. So for me, I go with ipilimumab and nivolumab, the NADINA trial. But if I'm very, very concerned that my patient is frail or I'm worried about the side effects, instead of going with the SWAG 1801, I may choose Opdualag. The grade 3 and 4 toxicity with Opdualag is 20%. The grade 3 and 4 toxicity with single agent immunotherapy is around 15%, while ipilimumab and nivolumab, I have to say, the grade 3 and 4 toxicity is 30%. It is so important to get these people into a major pathologic response, because when they get there, you will notice that the 2-year and the 3-year event-free survival are more than 95%. So that's the reason for me I would choose dual immunotherapy, and I think Opdualag is very reasonable. He's a white-haired guy, so maybe he's elderly guy, and I think they have chosen Opdualag, which I would definitely do that.
Yeah, it sounds like that's what the strategy is trying to get a major pathologic response when the Pembro wasn't cutting it. Another follow-up question. At what point in neoadjuvant therapy do you consider something a true failure versus pseudoprogression, and kind of what are the tools that you would use to really determine that?
Now, let me talk about that in the stage 4 disease. Let me talk about pseudoprogression in stage 4 disease, where I have a lot of time to really evaluate that. So basically, what we look at clinical data. The patients with a true progression, they will be having pain. You look at them, you open the door, they look really sick. They don't look good. They are losing weight. You look at some lab data, maybe the LDH is going up, maybe the calcium level is going up. So those are hints. Maybe they had a PET CT scan, and the PET CT scan is showing significant progression of disease, but you have to take it into the context of the clinical and lab data. And that's probably true progression. While people with not true progression or pseudo progression, which happens in stage 4, usually those people, when we start them on immunotherapy, they were very sick, and now they're coming with a Starbucks coffee and chatting with you, and they were barely able to talk. Well, they look good. There's no pain. The calcium level, if it was high, it's coming down. The LDH level is coming down. Maybe you had a PET CT scan, it's showing already less FDG avidity. So here it gives you a hint that, oh yeah, this is a pseudo progression. Now, in this setting, when you have just the 3 weeks, within the 3 weeks, you're giving 2 cycles of neoadjuvant treatment. Honest to God, it's very hard. I mean, usually most of the people present with a palpable mass. They don't have symptoms. I mean, you give them 2 cycles. Okay, he may tell you it grow in size, but you cannot really truly evaluate that unless you do really the completion lymph node dissection. The pathology will read it, and hopefully the pathologist will say we've got complete response, totally necrosis, hyalinized fibrosis. They give us those wonderful, phrases, or hopefully less than or equal 10% of viable melanoma. And then we know, wow, that has been pseudo progression. And there's a lot of times, I chat with the head and neck surgeon. I tell him, well, I'm really not happy about this guy. I mean, it looks like it's really growing. And then he calls me after he does the surgery. Guess what? It's complete response. So there is a discordance between radiologic response and pathologic response. And a lot of time, the radiology underestimate the pathologic response. And that has been seen in the NADINA trial, that has been seen in the SWAG 1801. So we have to be very careful. And I have to say it's extremely challenging when you have a very limited time to really know it without doing a completion lymph node dissection.
Great. Thank you so much. All right, Peter, why don't you keep on going?
I'll add one more point for the dual checkpoint. Therapy was not started necessarily as a neoadjuvant. Close to starting surgery, the patient was going on a cruise with his wife, and we kind of came together and had a discussion and said, don't change your major life events. Like, we'll still be here to do surgery when you get back. So it kind of bought him, in our minds, a little bit of time to keep going out and enjoying life before undergoing this major surgery. So October now, he underwent wide excision of the scalp with an outer table craniectomy, revision left level 5 neck dissection, and we did an anterolateral thigh free flap for scalp reconstruction. We excised a 7 by 12 centimeter ellipse down to the cranium and then burred the outer cortex down to bleeding marrow. In the level 5 neck dissection, there were multiple clinically positive nodes in level 5A and 5B. His pathology from this excision was residual melanoma within scar, thickness 6.5 millimeters, with ulceration. Negative margins on the soft tissue specimen. It was 0.6 millimeters from the deep aspect. And then we went ahead and removed the bone that was overlying that, and a mitotic rate of 7 per millimeter squared. He did have 7 lymph nodes positive in the specimen, and E&E was positive for a final pathology of T4B, N3A, M0, and additional BRF testing was sent, and that was negative.
It's a bad actor, this one. Quick question for Dr. Tillman. When you're dealing with a salvage case like this, what's your approach for the neck dissection? Are you typically just doing the full all levels, or are you tailoring it more to the index disease, the obvious clinical disease?
Sure. Can you show me the original picture? I think it depends on the situation. I think this is a hot topic, and it's a bit controversial. I think that it depends on what my most recent imaging, what my most recent PET shows. If there are any enlarged nodes whatsoever, or there were any previously abnormal nodes in another drainage basin, even if they've resolved, I would want to resect those personally. For this case in particular, I probably personally would add, the lateral neck to it. I would also make sure to address the suboccipital and retroauricular nodes. I think that's really, really critical for this case in particular. I just think it's very low morbidity, and potentially could be very helpful in the future. This man is really short on additional options. So that would be my take.
So after surgery, he completed radiation therapy in December of 2025, receiving 66 gray and 30 fractions, continuing on dual checkpoint inhibition for at least 1 year. But discussions with medical oncology indicate he could continue on longer. He's had 2 PET scans since then. Most recently was in March of 2026, and currently with no recurrent or metastatic disease.
Great case. Yeah, it's a nice looking flap too. Good job. Question for Dr. Mahmood. At what point, like Dr. Tillman just said, this patient has pretty dwindling options, if he continues to fail. And obviously, this is a really bad disease. It's got a lot of bad adverse factors, high risk factors. What step in the process do you switch to something kind of like a Hail Mary, like a tumor infiltrating lymphocyte therapy or an mRNA vaccine or some sort of a, early stage clinical trial?
Yeah, totally. I agree with you. I mean, he already got Keytruda, failing Keytruda, already getting Opdualag, and the pathology after the Opdualag and neoadjuvantly showed horrible disease. This is a high-risk melanoma. The nice thing about neoadjuvant treatment is nowadays we can do prognostication. So it's important for us to know who are going to be bad actors and who are going to do well. And that's nice to really know it upfront. And I'm frank with these people and be honest with them and tell them, like, this melanoma scares me, so I'm going to be monitoring you very carefully. If I have since you mentioned the mRNA, actually, we did have a study of pembrolizumab combined with mRNA in the adjuvant setting, and this resulted in a 44% decrease the risk of recurrence or death from melanoma compared to only pembrolizumab. So I think mRNA would be exciting. I don't know if this patient who already failed pembrolizumab and failed Opdualag would be qualified for such a clinical trial, but definitely if there is a clinical trial, adjuvant clinical trial, this is something I would be interested in that. Of course, the BRAF here is negative. Let's assume that the BRAF mutation was positive. We would have switched a person like this to BRAF targeted therapy to complete a full year. But unfortunately, his BRAF turned to be negative. In terms of the TIL therapy, currently the TIL therapy is approved for stage four melanoma after failure of checkpoint inhibitors. And if the patients had a BRAF mutation, they should have failed targeted therapy. So he would not be qualified at this point, but down the road, if he developed a disease that is not resectable or it's a stage 4 disease, then definitely TIL therapy would be the next option. If he has a good performance status, of course, to undergo the TIL therapy.
Great. All right. Thank you, guys. Great case, Peter. Thanks for that. Why don't we switch to Claudia? And unfortunately, sorry, Claudia, you have a little bit less time than everybody else, but I
Don't
have
worry, I talk fast.
confidence.
Okay. All right. So let me share my slides.
So this is sort of like a similar but different type of case to that last
Yeah,
one.
it's like a less of a happy ending. Okay. All right, can you see my screen? Does that look okay?
Yeah,
Looks
we
beautiful.
can.
Yeah,
Okay,
that
perfect.
shows there.
All right, so this is a 56-year-old gentleman. So I'm at the University of Miami. So we have patients that come from Central and South America quite a bit. So this is a gentleman from Ecuador. He has a history of extensive sun exposure, living at the equator, and he had a pigmented lesion of the left ear. 7 months prior to us meeting him, he had a known diagnosis of melanoma of the left ear, and he had undergone wide local excision, essentially was in the concha. And so they excised it. He had a skin graft placed, and he actually had a sentinel lymph node biopsy at that time. And we were able to overread that path. And so his initial staging was a T1A, depth of invasion of 0.6 millimeters, not ulcerated, and had zero mitotic figures. And interestingly, they did a sentinel lymph node biopsy at that time, even though based on our NCCN guidelines, it wasn't indicated, but it did come up as negative. So essentially, he was just undergoing surveillance. 1 month prior to us meeting him, he noted a new pigmented lesion of the same ear that was just inferior to where the skin graft had been placed. And he did have a biopsy in Ecuador, which we were again able to overread that path. And he ended up being diagnosed with a T1B at this point, and it was associated with a compound nevus. It was pretty neat. Their path report came with an image of the pathology, so you can see that you have this nevus that's kind of in this like within the tumor, which I thought was kind of interesting. And so again, no ulceration, no mitotic rate that was found, no LVI. And then this was a shave biopsy. And so the margins of the biopsy were involved with melanoma. So he came to us for treatment. So as part of his workup, he underwent a PET scan and a CT temporal bone as the melanotic lesions were kind of encroaching onto the EAC. So his PET scan was notable for a few findings that had lower SUVs, but were kind of concerning. He did have a left parotid deep lobe lesion that was less than a centimeter that was lighting up, and then multiple non-enlarged left cervical lymph nodes, but again, they're ranging from 1.5 to 2.6. Interestingly, his lesion didn't have FDG avidity, and so that's kind of why we decided to take these lesions seriously on his PET scan, even though they weren't necessarily hypermetabolic, but especially given since his primary site wasn't really lighting up either. And then notably, he didn't have any metastatic disease. We also got a CT temporal bone given the kind of encroachment on the EAC, and he didn't have any erosion of the canal.
I want to ask a quick question
Yeah,
to
go
Dr.
for it.
Tillman. How do you deal with, obviously, it's kind of an equivocal PET scan, right? Like you can kind of see some nodes in the parotid level too, but the FDG, the avidity is not very high. But you're concerned because this is a pretty ugly looking lesion. How do you deal with that? Do you often just assume these are positive, or are you doing biopsies, or I guess in your practice, what do you do with this?
Sure. I mean, I think if it was truly like a deep lobe, that would be very unusual, like in the classic sense. To me, this looks more like talar parotid, which gets called deep lobe more often. And it is certainly a site that I would expect this to metastasize to. So I am very lucky. I have an ultrasound in my office that I use as an adjunct to my physical exam. So I'd ultrasound it to start, look at the node itself, see the morphology, see if it has, an intact vascular, a little fatty hilum, any abnormalities. If I had a high suspicion, then I certainly would offer an FNA. But I'm also just a big fan of shared decision making. These aren't straightforward questions to be answered. And I think that if you really lay it out for the patient, hey, I'm worried about this lymph node. I don't know how accurate my biopsy would be. We can try it to get more information, but I'm still going to be worried about it. How do you feel about it? And I think most of the patients will make the decision for you, right? Because we're always scared to not be aggressive enough, but also to be too aggressive. And they really kind of they often make the decision along with me. And alternatively, you could continue to observe it, but I'd want to watch it very closely.
Yeah, that's great advice. Yeah, listen to your patients for sure. Obviously for the fellows, we're trying to decide if this is a patient who's going to get neoadjuvant therapy versus go straight to surgery. So
Mhm.
these are important questions for that reason. Claudia, do you mind going back to the actual picture of the ear lesion? I wanted to ask Dr.
Yeah.
Enslin. I don't know if you guys can see that very well. It's a little bit dark. What are ways we can differentiate just kind of like a irregular looking primary tumor that's all one thing versus some like microsatellite or some pigmented satellite lesions? I mean, because obviously that changes the staging quite a bit. Are there any ways that, is this something that you guys can tell with the dermoscope? I mean, how are we making this decision if this is satellite disease or just one tumor?
Yeah, so really it's whether there's normal intervening skin clinically. So melanoma should be primarily growing contiguously. It doesn't
Hmm.
have skip areas. So if I'm seeing lesions like I am here, and you see how kind of over the scaphoid fossa, it's pink and glossy, that to me actually looks like regressed tumor. So when your immune system is trying to fight off the cancer, right? You'll see regression under the microscope, and that is clinically what regression looks like. And you can see that there's then tumor right under the helix, right? And there's kind of the normal appearing skin in between. So this is obviously a very ugly looking melanoma. Looking at this, I would be concerned for satellite lesions, regression. You can see it's pink and looks like it's regressed down, extending into the external auditory meatus.
Hmm.
Uh, yeah, clinically, this looks very, very bad to me for
Yeah,
those reasons.
great.
And just to mention
Interesting.
the dermatoscope, there's a lot of specific features we see with our derm light that we're looking at. Looking at this with the naked eye, I think it's even kind of sufficient, but there's a lot of different nuances with the dermoscopy. So we absolutely always use that just to touch upon that.
Yeah, so I think that's a good message to the fellows. Like, if you have something like this, and you're unsure what the stage is, definitely have your, dermatology colleague take a really thorough look.
That's like, I'm glad you asked that question. I wouldn't have thought about that. That's pretty cool. And that kind of actually matches our final pathology. So
Yeah, I
he
don't want to
also
foreshadow too
saw,
much.
yeah, yeah, no, that was great. I mean, so he saw oncology as well. And he was actually started on the neoadjuvant Andina regimen, which I kind of have a question about a little bit later. And the plan had been for him to do the Nadina regimen followed by surgical resection. And our plan was to do a total reticulectomy, pyridectomy, and then a neck dissection. And then, depending on kind of how far the lesion went into the ear canal, he may need a sleeve resection or canaloplasty. I wasn't that familiar with the Nadina trial, to be honest. And so, um, just kind of to summarize, so essentially, this is doing neoadjuvant immunotherapy. And one of the key findings was that they found that 12-month event free survival was 83% with this treatment regimen versus 50% compared to upfront surgery. So there's kind of been a push for stage 3 resectable melanoma, starting with this immunotherapy regimen. And then in these patients, they had major pathologic response occurred in about 60% of them, and then no further adjuvant therapy was needed after the resection. So I thought that was pretty neat and like important to know about when seeing these cases. So unfortunately, he did not have a great response on the Najina regimen. He actually had pretty significant progression. He ended up having pretty obvious extension of the pigmented lesion into the EAC. So his resection was pretty drastic. So we did a total radiculectomy, total parotidectomy. We did preserve his facial nerve, and then he had an extensive left neck dissection. And then given the extension into his EAC that kind of clearly kept going, he ended up undergoing a lateral temporal bone resection. For his recon, I thought this was a pretty neat recon. We ended up doing a supraclavicular flap that was partially buried. So essentially you can see it here on the shoulder, and then coming up, we used it to fill the mastoidectomy and lateral temporal bone defect. And you can see we ended up kind of transplanting his tattoo to the side of his face.
Yeah, I think that's a great recon. It's a great option for that. And I think it's, for the fellows, you guys can kind of tell they've skin grafted the flap and used that for the donor site. So that's why it looks pink like that.
Yeah. So yeah, we always like skin graft first, and then that allows us not have to essentially like de-up the whole flap later. So you can just kind of tuck it in wherever you need to, which
Yeah,
is great.
that's nice. Question for Dr. Tillman. Obviously, in this case, we were concerned that there were deep lobe parotid nodes. So, I mean, it kind of makes sense that they did a total parotidectomy. Are there ever situations when you're doing a neck dissection for melanoma, specifically, where you would say it's okay to just do the superficial lobectomy rather than the whole total parotidectomy? I guess how do you approach that in your practice?
It's interesting you should ask that. So one of my mentors, Scott McLean, actually studied this, and he was a big proponent and still is for including the deep lobe. And when I say deep lobe, it's not an extensive deep lobe dissection. It's basically picking up your lowest branches and scooping that bit of that lower portion of the parotid. And he actually did this for some time and sent those specimens separately. And I don't remember. Can't quote the study off the top of my head, but certainly, it was included as a consideration in some of our guidelines to include those deep lobe nodes, particularly those inferior ones, because it's actually pretty common to find positive nodes there. And so I will always include those if I'm doing a parotidectomy personally.
Great, thanks.
So his final path was kind of abysmal. So he ended up having multiple positive nodes. So just in the neck dissection specimen, he had 14. Largest metastatic deposit was 4 millimeters. And then his left radiculectomy, it was a 2.1 millimeter lesion, left of invasion. And then he had multiple microsatellites, as we foreshadowed based on his initial pathology. And then he also had tumor infiltrating lymphocytes present. And then in our auriculectomy specimen, we had one larger lymph node kind of attached to that specimen, and that was positive for ENE. And then intraoperatively, that's kind of why we ended up doing such a big resection, is that it was pretty clear that he had quite extensive nodal disease. But the final margins were negative. And so kind of the main things is that he did have melanoma within lymphovascular space within 2 millimeters of the deep margin. And then he also had satellite metastasis within 2 millimeters of the deep ear canal margin. So his final staging, he was a T3A, so between the 2 to 4 millimeter depth of invasion without ulceration, and then he was at N3C. He had 14 lymph nodes that were positive ENE, and then microsatellite metastasis. So we did a tumor board discussion, and final plan for him was to do radiation. He was going to get 55 grays to level 1B. Could it just, Huh. Sorry, I just kind of closed on me. That was weird. Okay. Can you guys still hear me?
Yeah.
Okay, cool. So 55 grays to level 1B, because that's where we ended up seeing quite a bit of nodal disease. So 1B and 2B, and then 50 grays to all the others. And then his final path did show that he had a BRAF mutation. And so plan was for targeted therapy after radiation. And so BRAF mutation is one of the key like actionable drivers in melanoma. So we have quite a few immunotherapy options for that patient. So I did have a question, which was kind of why do the Nadina regimen prior to surgery instead of doing like targeted BRAF prior to surgery. I don't know if that question makes sense, but I just
Good
kind
question for Dr.
what you
Mahmood. Are
just
there
said.
any similar neoadjuvant trials that use targeted therapy?
Yeah, I mean, they have tried the neoadjuvant targeted therapy. Definitely, it's inferior to immunotherapy. And if you want to have a really great response, you got to have a complete response with neoadjuvant targeted therapy to even be closer to immunotherapy. So let me tell you about the Nadina trial a little bit, since Dr. Guterres was not familiar with it. So 2 cycles of ipi-nivo, you give it for clinically measurable disease. You need to have a lymph node at least 1 centimeter. Either you can feel it or it's an imaging. You give this 2 cycles. Within 3 weeks, the treatment is done. Then you take the patient to surgery week 5 or 6, and you do the completion lymph node dissection. We send the specimen to the pathologist. Then the pathologist will tell us it's a complete response, no viable melanoma. Great. It's near complete response, less than or equal 10% of viable melanoma cell, and the rest is gone, necrosis, and that's great news. Both of them, we call it a major pathologic response. And if you have a major pathologic response, and 60% of the people in the Nadina trial have a major pathologic response, if you look at their recurrence-free survival is more than 95%, and you are curing those people. And those people, and is the irony, is those people are the worst melanoma that somebody with stage 3 melanoma can have. It's a subgroup, I know, but the clinically measurable melanoma, we all know those are a very aggressive melanoma, and now we are curing them. And for the sentinel lymph node biopsy, stage 3 sentinel lymph node biopsy, we are treating them with a full year of immunotherapy. I mean, see how things changed. Seriously, I mean, those they do very, very well. Now, for the people who have a partial response, meaning more than 10% up to 50% melanoma cells, or no response, more than 50% melanoma cells, still here we look at the BRAF mutation. And that's what we call it, the pathology-tailored approach. We look at the BRAF mutation. Like your guy had a BRAF V600E mutation, we switch. So we switched to a targeted therapy for a full year. And we do the switch to targeted therapy, actually the recurrence-free survival for those people who are non-responders, still 83% when you switch to targeted therapy. So targeted therapy absolutely works. What is this old standard of care is doing completion lymph node dissection followed by adjuvant treatment, and you just quoted it. You said in the Nadina trial, compared to 57% recurrent-free survival. So imagine even this strategy by switching to target therapy is even doing much better than kind of sort of the old standard of care of doing completion lymph node dissection followed by adjuvant immunotherapy. Because there it's like 55 or I think 57% recurrence-free survival. While here, if you switch to target therapy, you get 83% in really like a disease like horrible, like this disease, best case you presented.
Our question really was, again, I'm not very familiar, but it's kind of, do you ever stop after just 1 cycle if you see that the patient is progressing? Like, is that something that we maybe could have intervened earlier to do surgery earlier? To be honest, I think this disease is so horrible.
No,
I don't know.
whenever you commit a person to neoadjuvant treatment, you and the surgeons and the team agree that this person is surgically resectable. So this is why we give neoadjuvant. If you believe he's not surgically resectable, now we are not talking about adjuvant treatment here, neoadjuvant. We are talking here about more locally advanced, unresectable disease, sort of stage 4, or you're treating similar to stage 4. But once you say we're going to give neoadjuvant treatment, within 3 weeks, 2 cycles are done, and then you take him to surgery. So I believe within this period of time, most of the people are going to be resected. Like this guy, you resected, but I mean, unfortunately, he didn't develop a response. But you did the NGS testing, and you did confirm that BRAF V600E mutation. Now you definitely have to switch him. And I agree with the adjuvant radiation because of the extranodal extension. I think close margin or something like that you mentioned. So
yeah, that's what I was. We're out of time, but that's one thing, because now we've had 2 cases that have had radiation, which is not super common in melanoma, outside of maybe desmoplastic disease. In your practice, Dr. Mahmood, what are the factors that are leading your tumor board to recommend adjuvant radiation for melanoma cases?
I think extranodal extension, we are doing it. And if it's very, very close margin with a bulky disease, but it's, we discuss it in a multidisciplinary, tumor board. As you know, also the radiation therapy or adjuvant radiation therapy leads to decreased risk of recurrence, but it doesn't improve the overall survival. So I think it needs to be discussed in a, multidisciplinary fashion and get the opinion from. But, this is what I can think of right now is extra nodal extension is a big thing.
Yeah. Great. I think we're out of time. If there are any burning questions, now's your chance. Otherwise, I think this was a great discussion. Super appreciative of our expert panelists. Thank you guys so much for your wisdom. I think you brought up some great points, and I think the fellows did a great job. And best of luck to you guys with your careers.
Chris, thank you for arranging. Also, thank you to our non-head and neck surgeon colleagues who are present, added a lot to the conversation. Just to prep people, the next few tumor boards are really interesting and special. I think a lot of us during fellowship really focus on reconstruction. And now that you guys, for those who are doing reconstructive fellowships, have a lot of reconstruction under your belt, so you'll get to hear about some interesting cases and how to think about reconstruction and the decisions around it. So we save those usually for kind of later in the year to build on the oncologic principles you guys have been building throughout. So we'll see you guys for the next few more tumor boards.
All right.
Thanks, everyone.
Thank you.